Is it clear?
Yeah, it's clear.
Yeah.
Go ahead.
So, good morning, afternoon, or evening, wherever you are, to all of you. Salams and greetings to all of you. I feel extremely honored and privileged to welcome you all to this first inaugural webinar program. Before we start the webinar, as tradition is from the past, I will just talk briefly about DFood International Mission with Vision. DFood International is a registered international non-profit association, and it's according to under the Belgium law. DFood International is truly a global organization consisting of people working in the field of diabetes-related food complications. All are dedicated to preventing food care and people with diabetes through awareness, education, and professional guidance. These people are spread across 7 regions in the world: Sub-Saharan Africa, South Central America region, Middle East, North Africa, North America and Caribbean, Europe, and Southeast Asia and Western Pacific. DFood International consists of following structure. We have a board members, then we have regional chairs for each region, then we have a regional advisory to the board, country representative, and full members from these 7 regions. Our mission is to promote the global profile of diabetes food prevention care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputation due to diabetes worldwide. Our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Training, our focus of action, training the healthcare workers how to manage diabetes-related food problems effective and obviously preventing amputation, giving healthcare professionals strategies to implement, develop, and sustain the food service, promoting the diabetes food specialist centers all over the world. So we should target to close the gap of available and affordable diabetes food care, especially in lower and middle income countries. DFood International activities during next 2 years, expected plans activities are as follow. Our programs, obviously expected activities, flagship programs, train the food trainer courses, and World Diabetes Awareness Week, which happens between 7th to 14th November, and all these other programs which are going to happen in next 2 years. 2 flagship programs are there, where train the food trainer courses, we'll have 5 in next 2 years in different 5 regions. And World Diabetes Awareness Week, we usually do it from 7th to 14th November, and each region takes 1 day, whereas we have a global meet, which is on 12th of November, where everybody gets together. Then we have a newsletters. First one came in July, and the second one came this month, and it has been coordinated by Rayaz, and this has been circulated all over through emails. Right. These are all other several projects which are going to happen in next 2 years. Several projects have been planned to equip healthcare professionals with knowledge, skills of excellent patient-centered care. All that has already been arranged in next 2 years. And this will be our biannual 8th Journal Assembly, which I'm already announcing it before 22 months to go. It will be happening in Malaysia, where I'll be handing over to our president-elect, Perry on 15th of June, 2025. Now, webinars, which we are here today, every Saturday every 3 months, we have this on Saturdays between 2 to 3 p.m. Central European Time. And these are already arranged. The first one, which we are going to have today by Professor Rayaz Malik, and the rest you can see up till 7th of September next year have already been organized. Today's webinar's registration, we have about 448 delegates from 75 countries, and this was last recorded at 1 Central European Time. Now coming to the main thing, I feel extremely honored and privileged to introduce our speaker for this first inaugural webinar program, Professor Rayaz Malik. Rayaz Malik is a consultant physician, endocrinologist, and professor of medicine from Doha, Qatar. He graduated in medicine from University of Aberdeen in 1991, obtained his MRCP in London in 1996. PhD was done from the University of Manchester in 1997, became a fellow of Royal College of Physicians in 2007. In 2008, he became a professor of medicine's consultant physician in the Central Manchester University Teaching Hospital, where we know all of us, and the University of Manchester. He remains an honorary professor of medicine at the University of Manchester and visiting professor of medicine at Manchester Metropolitan University. In 2014, he was appointed as a professor of medicine at Wellcome Medicine and senior consultant physician in Hamed General Hospital. He was appointed as an organizational officer in November 2016 and as an assistant dean for clinical research at Wellcome Medical Qatar in February 2019. Rayaz Malik, over 20 years, he has pioneered the use of corneal confocal microscopy, which we all are aware of that, a non-invasive ophthalmic instrument to quantify neurodegeneration in multiple peripheral neuropathies and in patients with multiple sclerosis, Parkinson's disease, stroke, dementia, autism, and long COVID. Based on independent expert score analysis, the world-leading index of academic achievement and expertise in healthcare in 2022, Professor Rayaz Malik was ranked second most influential research on diabetes complications in the UK and seventh most influential research on diabetes complications in the world. In 2023, Research.com ranked him as #1 researcher medicine in Qatar. He has published more than 450 peer-reviewed papers and has a Web of Science H-index 72. This is a remarkable achievement. Congratulations. And citations of his paper has been more than 20,600 and Google Scholar H-index 94 and has been quoted I-10 index of 366 papers. I feel extremely honored and privileged to welcome our speaker, Professor Rayaz Malik, for this first inaugural webinar program. And he's going to talk on diabetic neuropathy, a time to challenge the dogma. All the questions can be posted on Q&A sections during this talk and we'll discuss. Welcome, Rayaz.
Thank you, Zulfikar. I just need to get my slides opened and then I will start my lecture. I'm still disabled at the moment, so somebody needs to enable me to share my screen. Nope, still. I think somebody needs to take away your from you as being the host and allow me to become the host.
Ali?
The IT person.
Yes, working on it.
Okay. Let me know when you've done it, then I can.
You may proceed.
Okay. Yeah. Okay, so I think I'm in, and I hope you can see my slides. So firstly, thank you, Abbas, for asking me to kick off your webinar sessions on a topic which is dear to my heart. And I've entitled it deliberately, Diabetic Neuropathy, A Time to Challenge the Dogma. And it actually follows on from a lecture I gave as a part of the Camilo Golgi Prize, which again, I wanted people to start asking questions about what we're doing at the moment and how we can do things better. So these are my disclosures in terms of advisory boards and lectures and scientific grants. But as you will notice from behind me, there is really only one disclosure or conflict of interest I have to make. And that is that despite the problems we're having at the moment, I remain a Manchester United fan. That's sensational. Okay, so what my title was Dogma. So what is dogma? Well, dogma, the official definition is it's a belief or set of beliefs held by a group or organization which others are expected to accept without argument. And unfortunately, as medical practitioners, we are one of the worst group to accept dogma very readily, because from medical school to being SHOs to registrars to whatever, we never challenge actually pretty much what is said from on high. And I think there comes a time when we have to do this if we're going to make progress. Also, in way of, I guess, background to get people to start thinking about the concepts that I'm going to put forward, I put up this, one of my favorite films, actually, Clint Eastwood, called The Good, the Bad, and the Ugly. And hopefully what I'll do is I'll put my lecturing context in relation to this. So what is the ugly fact about diabetic neuropathy? Well, the ugly fact about diabetic neuropathy is exactly what, Abbas and BJ have been trying to change, which is that we are all in this game to prevent this complication. Actually, to prevent foot ulcers in the first place, but really to prevent amputation. So how do we do this? Well, I think the major challenge, honestly, I believe, is in relation to diagnosing the key underlying defect that leads to this, which is diabetic neuropathy. And diabetic neuropathy, Machiavelli said, as the doctors say of a wasting disease, to start with, it is easy to cure, but difficult to diagnose. After a time, unless it has been diagnosed and treated at the outset, it becomes easy to diagnose, but difficult to cure. And that is the challenge that we have for managing people with diabetic foot. It's not difficult to diagnose somebody with a diabetic foot, but I would say the challenge lies in identifying the underlying diseases or disease which leads to the diabetic foot, which we ought to be making efforts in primary care before the foot arrives to us in secondary care. And so, for context, the bad, again, to me, is how we diagnose diabetic neuropathy. For retinopathy, we now have amazing techniques, visual techniques, dilated fundoscopy, or even non-dilated fundoscopy, actually, 7-field fundus photography, OCT. For renal disease, microalbuminuria, easy ways to manage, to diagnose early diabetic neuropathy. But for diabetic neuropathy, unfortunately, we still remain stuck in the neurological exam and the monofilament. And honestly, the monofilament I do not have a problem with if you want to diagnose advanced diabetic neuropathy. If you want to diagnose the patient who's already got a foot ulcer or is at risk of getting a foot ulcer, we still need to do it. And actually, we're not doing enough of it. And I think that's another key message that should come out. But we need to move to a stage where we are well before this advanced diabetic neuropathy. And actually in clinics, we need to start thinking about diabetic neuropathy beyond. So the average practitioner who deals with people with diabetes spends most of their time, and this is a study that we did across the Southeast Asian region, where we asked the question, 2 practitioners, where do you focus your attentions? Well, whether it was Hong Kong, Malaysia, Philippines, Taiwan, Thailand, most people, when the diabetic patient comes through the clinic, they start asking about HbA1c, kidney function, lipid disorders, diabetic neuropathy, or in fact, even painful neuropathy here, which is, I think, relatively easy to diagnose. You can see very little. Philippines actually applaud, 79% did ask about it, but you can see the others really were not bothered about asking about this condition. And for us in Qatar, actually, when I moved here 9 years ago now, we initially did some studies because I believed that people weren't taking this condition seriously. So we did a study in about 1,000 patients about painful diabetic neuropathy, and we identified that actually 34% of people had painful diabetic neuropathy. And as you know, most European studies would say, well, 20% have painful diabetic neuropathy, so much higher. And we also showed that the prevalence of painful diabetic neuropathy was actually much higher because it infected the Qatari Arabs, the non-Qatari Arabs, more so than the Caucasians. So you can see the data for the Europeans is 22%, which is in keeping with the studies from Europe and North America. Painful diabetic neuropathy is about 20%. But you can see the Arabs had a much higher prevalence. And one of the reasons was because there was more obesity. Actually, obesity was a major risk factor for the painful diabetic neuropathy. But the most incredible thing was that of these people, 34% that we diagnosed in our clinics, 80% had not previously been diagnosed or treated. They simply had gone to clinics and nobody had asked them about painful diabetic neuropathy. So that was in Qatar. So we then extended this study actually out into the Gulf region. And what we showed is similar figures, which is that diabetic peripheral neuropathy affects actually about 35% of people. Those with neuropathy, high risk of diabetic foot ulceration, you can see up to 50%. But thankfully, the people with diabetic foot ulceration actually was relatively low. And that's, again, something that seems to be a consistent feature that in some areas, and we showed this actually when I was still in Manchester with Andrew Bolton, that Asians have less foot ulceration, even though they have a higher prevalence of diabetic neuropathy. And maybe that's to do with the practice of how we look at our feet, maybe 5 times a day, wash our feet. Maybe that is something that's important. But again, you see painful diabetic neuropathy affecting about 30%. But half of these patients had not been previously diagnosed. And if you look at the risk factors, you can see for peripheral neuropathy, actually, it is age, it is having poorer glycemic control, hyperlipidemia, hypertension. And I'll come back to this. So what are we doing wrong? Why aren't we diagnosing diabetic neuropathy earlier? Well, one of the key reasons, and I keep talking about this, and I don't know whether people listen to me, but, is that when we look at diabetic neuropathy, we unfortunately are focused very much on using tests like neurological exam, like the monofilament, like vibration perception, which is focused on the A beta fibers, large myelinated nerve fibers. And, there's nothing wrong with that because, of course, we think about sensation, loss of proprioception as being a key feature of diabetic neuropathy, losing sensory perception, and therefore predisposing ourselves or our diabetic patients to develop a foot ulcer. But I want you to accept something else, which is that there are these other fibers, which are these small C fibers. And we kind of conveniently or inconveniently ignore these small fibers. And yet, small fibers, we know, are, they're central to perception of pain. And indeed, it is these small C fibers that are damaged in diabetes, the intraepidermal nerve fibers, which actually are signaling pain. And this we know is an early feature. And also, small fibers are, they are beyond just pain regulators. They actually are intrinsic, central to the mechanisms which underlie, actually, I believe, foot ulceration. So they are the fibers that give us that warning signal that we have an injury, but they also regulate blood flow and inflammation, which are key to the whole concept or the whole mechanism of why patients, the skin begins to break down. So this is data from Jerry Raymond, now almost 30 years old, that shows you how important these small fibers are. So their study published in the BMJ showed that in people with diabetes, there is something called an impaired hyperemic response to minor skin trauma. What is this? Well, if I was to put my foot on something sharp, it would not only give me a signal saying this is sharp, move away, but actually it induces increased skin blood flow to that area of skin on which there has been this pin or trauma, to improve blood flow, to stop the tissue from breaking down. So this is the hyperemic response. You see this in controls, high, whereas in the diabetic patients, you can see it's blunted. So for that insult, there is less tissue blood flow. And when you have less tissue blood flow, that's when the skin breaks down. So that's one aspect. The other aspect is something that Fromi and colleagues from France have been talking about for almost 20, 30 years. And again, very few people listen to this or have maybe read these papers. So this is a basic physiological response. When I put pressure on the bottom of the skin of my foot, for example, there is a certain amount of pressure which reduces the amount of blood flow to that area of skin that then leads to breakdown of that tissue. If you look at a healthy control, you need 48 millimeters mercury of pressure, which is a large pressure to reduce that blood flow. Whereas if you look in a diabetic patient with and without diabetic neuropathy, you only need 6 millimeters mercury of pressure, very small amount of pressure, and you've reduced the blood flow to that area of skin, which then predisposes it to developing an ulcer. So again, small fibers, very important. And even when you've got a diabetic foot ulcer, small fibers are actually really, really important in releasing substances like substance P, VIP, that actually help to heal that foot ulcer. So if you have none of these small fibers or inadequate numbers of small fibers, you don't get these substances released, and the whole process of wound healing, you can offload as much as you want, but it has to start to heal. The inflammatory phase, the proliferative phase, the remodeling phase, all depends on these small fibers to produce adequate amounts of these peptides that will help to heal the foot ulcer. So here's where we have to start to challenge the dogma. And this is actually a video from one of my other all-time favorite films, which is Gladiator. And I put this up because there is in Gladiator, Marcus Aurelius is mentioned. Marcus Aurelius was this famous emperor and philosopher. And he said, we need to learn to measure what we value. And this is what he's saying here, actually, in the film. What we value, not value what we can easily measure. And while we can easily measure monofilament vibration sense, but if we're not looking at the small fibers, then we're not doing a service to our patients. And so we need to open our minds and have the courage to throw out yesterday's ideas and challenge the dogma when they don't appear to be working. And whilst monofilament vibration sense is important in advanced disease, I really feel that we are failing our patients if we are totally relying on these measures. And that's where corneal confocal microscopy comes in. And of course, some people say, well, corneal confocal microscopy measures these central fibers in the close to the brain. But this is what it does. It measures actually small fibers, and it does it very easily and very sensitively. That's the most important thing. It picks up disease at a very early stage. And Einstein said, how we think determines what we measure. So here's where it starts. And unfortunately, this slide is getting older and older and older. This is like 2001, which is 20 years ago, when we got interested. We got a little grant from the JDRF to look to see whether CCM can actually pick up small fiber damage in diabetic neuropathy. And actually 2003, we published 20 years ago, our first paper showing that corneal confocal microscopy can indeed measure small fibers, which are a reflection of what is going on in terms of severity of neuropathy. But the most important, I think, finding here was that even in these patients without neuropathy, very early stage, that you would measure using vibration or monofilament or nerve conduction, actually we were already seeing a loss of these small fibers. What are we actually looking at? Well, we look at images from the cornea, and these white lines that you see here are the nerve fibers, the small C fibers. What we've managed to develop over the years is ways of quantifying these nerve fibers in terms of fiber density, fiber length, and branch density. And the good that I believe is happening is that this is able to now measure these small nerve fibers in these patients, and it relates to the pain, but also to the underlying small fiber damage that might be occurring. So here's the original study where we showed that even in mild patients, you can see that there is a loss of nerve fibers. We've now followed this up, actually, and this is where, monofilament is fine, but this is only going to pick up at the advanced stage of severe neuropathy. And we've now gone on to show that in over 38 studies, 4,000 patients, exactly the same, that corneal confocal microscopy picks up patient nerve damage in those with established neuropathy, but also in those with mild subclinical neuropathy. Everybody is talking about AI at the moment and how it's a challenge. Well, actually, we've harnessed AI to really, really take CCM to the next level. And what we've used is something called logic-based fuzzy inference, okay? And essentially, this takes away from me measuring the nerves to simply scanning somebody's eye and coming out with an answer, whether or not this is or isn't diabetic neuropathy with high sensitivity and specificity. So deep learning has been used on images from the cornea. And what we essentially show is that to differentiate healthy controls from those with diabetic neuropathy, of 100% sensitivity. It doesn't get any of them wrong, right? And even differentiating those with and without diabetic neuropathy, we're actually 95% AUC. Beyond that, we've shown that in children with type 1 diabetes, already there is actually a loss of corneal nerves. Whether it's CNFD, CNBD, CNFL, CNFT, there are changes. And in the inferior wall. So there is, even in children with type 1 diabetes, there is already a loss of others. And, this is in children who have normal biothesiometry, normal monofilament, they have no symptoms. We've also now started to look at kids who are obese. And what we show is, you can see here, the average weight of these kids, unfortunately, was really very high, 100 kilograms. And they had different degrees of glucose tolerance. So some had type 2 diabetes, some were impaired glucose tolerance, some were even still normal glucose tolerant. But you can see HbA1c in the diabetic patients was high. They also had higher cholesterol and other risk factors. But what we are able to show is that corneal nerve confocal microscopy actually shows this progressive loss of nerve fibers, especially in the fat, overweight diabetic kids. But you can see even in those with impaired glucose tolerance, there is also already a reduction. Painful diabetic neuropathy, well, small fibers are important, but we've actually shown that in people with painful diabetic neuropathy, there is less corneal nerve fibers compared to those with painless diabetic neuropathy compared to healthy controls. Moreover, this relates to the severity of pain and the quality of life. So, the corneal confocal microscopy is really giving a handle of how badly the patient is feeling the pain and how it's affecting their quality of life. And in fact, the severity of pain, again, the less the nerve fibers, the more severe the pain. Coming back to diabetic foot, this is actually a study that we did now over 7-8 years ago. This was a longitudinal study where we were measuring corneal confocal microscopy alongside nerve conduction, vibration perception, and there was actually one patient who, over time, over 6 years, initially developed a diabetic foot ulcer and then developed a Charcot foot. So we went back and looked at what was a change in terms of the measures of neuropathy. When this patient developed a foot ulcer, had an amputation, developed a Charcot foot. Well, if you looked at their nerve NDS, which is the neurological exam, cold perception threshold, warm perception threshold, vibration perception, nerve conduction, over this period of time, when this patient actually was developing a foot ulcer and developing nothing changed. But look what happened to corneal confocal microscopy. Before they got their toe ulceration, before they got their amputation, you can see the fall off of nerve fibers, and particularly before the right Charcot foot developed. So really a loss of nerve fibers, kind of almost telling you that this is a measure that can predict these bad things. And we then went on with a consortium study from the NIH where we had over 1,000 people followed over 4 years. And we basically selected out 261 people who had no neuropathy at the baseline. We then followed them over 6 years, and 23% developed clinical diabetic neuropathy according to Toronto criteria with abnormal nerve conduction, symptoms and signs. And we then went back and looked at what was different between those who developed neuropathy compared to those who didn't develop neuropathy. Well, actually, they were more overweight. Those who developed neuropathy were more overweight. But their HbA1c didn't differ, actually, and nor did their LDL cholesterol. There were also signs and symptoms that sural nerve conduction was admittedly lower, but look at corneal confocal microscopy. Corneal nerve fiber length, branch density, and fiber density were lower, already at baseline, in those who developed neuropathy compared to those who didn't develop diabetic neuropathy. And we used a cutoff of 14 for corneal nerve fiber length to differentiate those who developed, so really predicting those who develop diabetic neuropathy. So is there anything we can do for diabetic neuropathy, or do we just use a corneal confocal microscope and say, okay, you've got early diabetic neuropathy, and then you just commiserate with the patient? Well, if we think about two aspects of diabetic neuropathy, which is painful diabetic neuropathy and diabetic neuropathy, the most recent data about painful diabetic neuropathy is, I would say, somewhat disappointing. Solomon Tesfaye published this in The Lancet. This is a very complicated trial, a multi-center, randomized, double-blind, center-stratified, multi-period crossover trial. Now, I'm a simple man, and I kind of thought, well, how the hell do I make sense of this? Well, it's actually really very simple. This is a trial that I think recapitulates what we do in clinical practice, which is patient walks in through the door, says I've got painful diabetic neuropathy, and depending on that day, whether I'm thinking that pregabalin is the best thing, or duloxetine is the best thing, or amitriptyline is the best thing, I'll start them on it. If it works, fine, thank you very much, goodbye. If it doesn't, then I'll think about an alternate drug, or I'll think about combining drugs. And that's what this study did. So essentially, they compared amitriptyline against duloxetine or pregabalin. If it worked, great. If it didn't, then they added another drug to combine and looked at the effect. Bottom line was, actually, it didn't matter whether you use amitriptyline, duloxetine, or pregabalin. They all had a similar effect in terms of pain relief. But if you look at the pain relief, it went from about 6, didn't really completely ever go away. It was only about 50% relief. And of course, you had the side effects. And even when the combinations were used, actually, again, greater than 50% pain relief was always below 50%. So to me, if I look at this, I think, yes, it works, but not particularly amazingly. So have we got alternatives? Well, one of the alternatives I've been talking again for a long time, and I hope somebody listens, is vitamin D. So we showed, actually, again, we actually did the study about 10 years ago, eventually published it in 2021. But essentially, the key message from our study and from a study in Sheffield is that people with painful diabetic neuropathy have lower levels of vitamin D, okay, and significantly lower. And then we actually did a study with the Buckeye Institute in Karachi where we gave vitamin D, but we gave it intramuscularly, 600,000 international units, and we looked at the effect on pain. And what we showed very clearly is that there is a reduction in pain, which is as good as pregabalin, gabapentin, duloxetine, amitriptyline, with just giving vitamin D. And interestingly, these patients, even at baseline, they had what most people would say is a healthy level of vitamin D, 31 nanograms. And yet when we gave the vitamin D, it went up to 46 and we got pain relief. So now, honestly, as a starting point, I always check vitamin D in my patients with painful diabetic neuropathy, and I give them actually 50,000 units daily for 10 days, and then 50 to 100,000 units once weekly. The other vitamin which is commonly used across the board here actually is B12. And I must say, when I first came to this region, particularly in the Middle East, I thought, you know what, this is crazy. Why are they giving B12 in people who aren't vitamin B12 deficient? And yet, there's a claim that it's beneficial. But now, actually, there is some data published from Greece, which shows that not necessarily intramuscular, but oral vitamin B12, 1,000 micrograms against placebo over 12 months does benefit diabetic neuropathy. So this is a study, and it's not in people who've got low levels of vitamin B12. So if you look at this, in the baseline, 232 picomoles per liter, which isn't low, it's on the low side, but it's not very low. But when they gave B12 orally, it went up to 770. And this was associated with an improvement in quality of life, improvement in the pain score, even improvement in nerve conductions. And again, in the placebo arm, you can see, really not very much changed. So is there anything we can really do for diabetic neuropathy? The painful neuropathy is one aspect, but what about the underlying disease itself? Well, actually, if we look, there's the bad again, it comes back in, the good, the bad, and the ugly. Unfortunately, we have multiple failed clinical trials for diabetic neuropathy. And one of the key things I think, again, comes back to endpoints. I honestly believe that using tests like monofilament, neurological exam, and even nerve conduction and skin biopsy has not done us a favor in terms of looking at new therapies for diabetic neuropathy. And I think, again, we need to think about, something that will challenge this. So we've had some great, hope that something like a PTSA beta inhibitor, alpha lipoic acid, VEGF therapy, benfotiamine, C-peptide will work. All of them have failed in clinical trials. But yet we know that there are risk factors for diabetic neuropathy that we could treat tomorrow in our clinic with currently available drugs, and we aren't really doing as much as we should. And if you look, this is again a study published in the New England Journal of Medicine by Solomon Tesfaye almost 20 years ago, showing that there are risk factors, metabolic risk factors, not just metabolic, but cardiovascular risk factors, hypertension, smoking, being overweight, having higher triglycerides, total cholesterol. And we've actually confirmed this in type 2 diabetes. That was in type 1 diabetes. This is in type 2 diabetes. In a study done in the region, in the Gulf, we've shown that exactly the same risk factors for diabetic neuropathy and painful diabetic neuropathy, poorer glycemic control, hyperlipidemia, hypertension, being more overweight, being less physically active, smoking cigarettes, all of these are risk factors for diabetic neuropathy. And then if you treat this, we showed now 1998. That's like, it's a long time ago, 5 years ago, where we showed in Manchester that if you give an ACE inhibitor to patients who are normotensive, not microalbuminuric, you can actually improve their nerve conduction. I wish I had CCM then, because I'm sure that would have shown even greater response, but nevertheless, there is an effect. So this is in normotensive individuals, but there is also a study in hypertensive type 2 diabetic patients with albuminuria from Italy. These are 380 patients, treated actually with a calcium channel blocker or an ACE inhibitor or a combination of both. And they looked at the effect on neuropathy. At 3 years, new onset neuropathy, and even people who'd got diabetic neuropathy, whether or not they could improve it. And what they consistently showed is that both combination, calcium channel blocker and ACE inhibitor or ACE inhibitor alone, had prevented the development of neuropathy and also the progression of neuropathy, but also actually improved neuropathy in those who already had neuropathy. HbA1c, well, HbA1c, the drugs that we use obviously are insulin, or there is now a study that we've done in Qatar where we looked at the effect of pioglitazone with once weekly exenatide. And we basically showed that if you get people who are poorly controlled, 10.5% HbA1c, if you put them on basal bolus insulin or a GLP-1 therapy with pioglitazone, you can improve their HbA1c down to 7%. But we also did corneal confocal microscopy. And what we showed is that their nerves start to repair. So in type 2 diabetes, we are now showing that these therapies actually, beyond lowering glucose, are now improving their nerves. BMI, well, physical activity. We have now shown, again in Qatar, if you take two cohorts of people, there are those who are physically inactive and those who are physically active. 30 minutes of walking 3 times a week is physical activity in this study. We followed them over 2 years and we looked at their corneal nerves. What we showed is that if you're physically active, that is 30 minutes of walking 3 times a week, then the blue you see here, there is repair of nerves. If you are physically inactive, you get a progressive loss of nerve fibers. And we are now in the middle of a study actually with semaglutide, and this is early 6-month data, where we've taken people who were actually probably on the overweight side, but diabetic and non-diabetic, given semaglutide. And what you see is, whether you're diabetic or non-diabetic, you see this weight loss of around 7-8 kilograms over 6 months. And what we're starting to see is repair of nerve fibers. Admittedly, at the moment, not significant, but I can tell you I have now got 12 months data that is showing there is a significant repair of nerve fibers. Triglycerides, well, you will be familiar with the fenofibrate field trial study that was done. And this was an amazing outcome at the time, because when you looked at the results, you thought, this can't be true. How can fenofibrate, something that lowers triglycerides, reduce minor amputation by 50%? Well, nobody really understood why this was happening. But now there is a study that's just been published in Diabetes that has looked at, in 30 patients with type 2 diabetes, fenofibrate 100 to 300 milligrams only over 30 days. And look what they looked at. They showed that you could see HbA1c actually really very well controlled. There was an impact on triglycerides. It did lower it by 0.4 millimoles, but look at what else it did. Corneal confocal microscopy was able to show there is a repair of nerves within 30 days of fenofibrate. Small nerve fibers are beginning to repair. The other thing is omega-3. Some people use it particularly for triglyceride lowering or post-MI. This is a study from Australia which looked at the effect on neuropathy over 280 days. And they looked at MNSI, MDNS, quality of life, QSART, nerve conductions, excitability. And guess what they found after 280 days to these measures? Absolutely nothing improved. But guess what did improve? Corneal confocal microscopy. Corneal nerves, you can see here, over 180 days, were starting to repair. Corneal nerve fiber density, branch density, and fiber density. I'm going to finish off now because I'm focused on diabetic neuropathy and foot ulcers, and hopefully you've got the message, right? But just a few slides on CCM for CNS disease, because obviously corneal nerves are like pretty close to the brain. So dementia, Parkinson's, multiple sclerosis, autism even. And what we've looked at is whether or not CCM might be able to measure what's going on in terms of neurodegeneration in the brain. So for Parkinson's disease, we started in 2016, but the most recent data I've got with collaborators in China is actually looking at different type of, so, you know, people with Parkinson's have different types of movement disorders. So there are those with tardive kind of movements. There are those with mixed type of, and what we essentially show is that they have less nerves in all of these, and maybe there are differences between them. But in short, corneal confocal microscopy is able to detect differences in terms of the different subtypes of Parkinson's, but also is able to diagnose from healthy controls compared to these people with Parkinson's. The other thing we looked at is multiple sclerosis in Qatar, where we've shown that people with multiple sclerosis, beyond MRI, when you use their corneal nerves, looked at their corneal nerves, they have actually less nerves in those with severe multiple sclerosis. And this is actually a grant we got from ECTRIMS. And we again show that across the board, whether it's even in people actually with clinically isolated syndrome, which we think is not really MS, there is already a drop, but particularly in patients with relapsing, remitting, and secondary progressive multiple sclerosis. And the last one is to do with actually dementia. And the Gates Foundation put in $100 million, not to me, but to looking at the problem of why we are getting it so wrong in dementia. And Bill Gates actually made a very important observation, and it comes back to what I believe we're doing wrong in diabetic neuropathy and diabetic foot. And he said that what we're doing wrong in Alzheimer's is we're waiting until the symptoms show. So in the world of diabetic foot, we're waiting until the patient comes with a foot ulcer. What he said is that what we need for really fixing Alzheimer's is we need tests that can pick up the disease earlier. We need reliable, affordable, accessible biomarkers. And this has the potential to revolutionize how we approach Alzheimer's disease. So does corneal confocal microscopy have anything to do with dementia? Well, actually it does. We've shown that in mild cognitive impairment and dementia, there is actually a loss of nerve fibers compared to healthy controls, non-cognitively normal individuals. And this is better actually than MRI. So in MRI, when we use MRI, in mild cognitive impairment, we see no loss of hippocampal volume or gray matter volume. In dementia, yes, we do. But look at corneal nerve fiber density, branch density, and length. Already in people with mild cognitive impairment, before they get dementia, there is already a loss of nerve fibers. And Thomas Campbell said, coming events cast their shadows before. And what we've shown is that if we take 107 people with mild cognitive impairment, we followed them, much like the neuropathy study, a proportion developed dementia. And what we've been able to show is that actually corneal nerves, loss of corneal nerves predicts, alongside hippocampal volume and whole brain volume, those who develop dementia. So my almost last slide, challenging the dogma hasn't been easy. And I want to put up again a video to wake you all up if you've been asleep. And this is the challenge that I've had, actually. And I'll let you choose. So this is a scene from the Avengers. I'm not Captain America, by the way. But these are some of my people who have challenged us along the way in terms of particularly corneal confocal microscopy. This is what's going to happen to those who challenge us. So Muhammad Ali said, he who is not courageous enough to take risks will accomplish nothing in life. Alhamdulillah, we are in a state where we started with one crazy idea in Manchester and then other people like Bruce Perkins picked up on this, and Utah. And now really there are many centers that are undertaking corneal confocal microscopy in India, in Malaysia, in the Far East, in Australia, Africa. Thank you. Okay.
Thank you, Rayaz. Thank you very much. It's always been excellent, very clear and to the point. Thank you very much, Rayaz. We'll open for discussion now. Let me start and then I'll put put to the panelist. Yes, do small fiber abnormalities underlie the development of foot ulcers? My question would be mostly for low and middle income countries. So I repeat, do small fibers abnormalities underlie the development of foot ulcers? That's number one. Number two, you mentioned about monofilament. So I also remember you once said too little is too late. Is the monofilament an adequate screening tool for painful diabetic neuropathy? And then I'll tell you the third one. Let's go.
Okay. So yes, I think honestly, the small fiber bit, I showed you the data, in terms of hyperemic response, in terms of pressure-induced vasodilation. I think we need to start thinking about how these small fibers really play an integral part in the development of the foot ulcer, but also in the wound healing. And for too long, we've kind of thought about a loss of sensation being the most important bit, that then magically, this skin falls apart. Well, it's not magic, it's physiology, it's medicine. The reason that skin falls apart more readily in our diabetic patients is because those physiological responses that would maintain that skin are no longer there. And that's why there is inadequate, blood flow to that area, the pressure-induced vasodilation doesn't occur. And that's why we get the patient with a foot ulcer. So that to me is a key part, a message that needs to go out to everybody. The small fibers are really important. For painful diabetic neuropathy, absolutely not. Monofilament is a waste of time. And it actually does a disservice, because when a patient comes into you and says, I've got painful symptoms, you do a monofilament and it's normal, and you say, oh, you haven't got painful neuropathy. That's the wrong thing. And I've seen it too many times.
That's really wonderful. A good message. It will go across to all these 200 delegates from 75. Thank you very much. Vijay, you have your hand up.
Yeah, yeah. Professor Rayaz, fantastic talk as usual. So, talking about semaglutide, I had an opportunity to write an article on diabetic neuropathy in Lancet Neurology, along with Eva Feldman last year. So we wrote about SGLT2 inhibitors improving neuropathy. Do you think that these drugs, semaglutide, SGLT2, have got a specific role in neuropathy, or is it only reduction in body mass index? Thank you.
Okay, so that's a good question, because actually it gets to the heart of the matter, which is, I believe that there is clearly a role that GLP-1 receptor agonists play in terms of lowering HbA1c, lowering triglycerides, lowering blood pressure. But beyond that, we now know that there are actually receptors, GLP-1 receptors on nerves. And there is a lot of basic experimental data that shows that it is the action of these additional actions of GLP-1 on neurons, which causes the repair of the nerves, beyond and above what we are already getting from the reduction in risk factors. Yeah. And SGLT2,
yes,
actually, I'm not sure. Again, there are data coming through suggesting that there may be a benefit on neuropathy. And in fact, I'm currently analyzing some CCM from India. There is a study, it's collaborators that they've done a study where we've looked at patients before and after SGLT2 inhibitors. We'll see. Watch this space yet, what we see.
Yes, Zahid.
Hi, Assalamu alaikum. Thank you very much. What a great lecture, talk, as always. Amazing talk. And you show a lot of work about the neuropathy and the CCM. And I think you started your first lecture in Pakistan when you come over there in 2002 or 3 about the CCM. And the people were saying, what he is talking about now. Now everyone is realizing that yes, this is look like a future aspect of the future monofilament like this. So one thing which I have in my mind, I wish we can have the CCM in our country, as we discussed with you and many times. But unfortunately, we cannot have right now. The other clinical aspect of knowing that the small fiber are there. So you're talking a lot about the small fiber, and now we understand that yes, the small fiber are the important fiber. So there are some clinical diagnostic tests which can help in that, yes, this is the small fiber things which is going on.
Yeah. So, sorry, carry on.
Yeah, which we are actually missing in clinical diagnosis, which we are not doing actually in our clinical practice.
Yeah. So you know, to me, honestly, if you and I think it's important, you know, CCM is great for me in Qatar, right? But like you say, you know, if you can't get it in Pakistan, then you can't use it, right? But you know, asking a simple question: do you have pain? Painful neuropathy, we know, is mediated by the small fibers, right? So that's you don't even need an exam. Pain perception, thermal perception, they are a little bit more. They're not exact, but at least they are telling you, giving you a handle of small fiber damage. Pseudomotor function, actually sweating. You know, there are tests now that are maybe a little bit more like the Neuropad. We've done work on that, pseudoscan. So those are all kind of tests that are in a roundabout way does give you a handle of small fibers.
That's true. That's true. Thank you. Thank you. Thank you very much for great talk.
Thank you, Rayaz. Thank you. I'll take few from the box. Professor Felicia from Nigeria, she's asking, in low or middle income countries where CCM is not available, what should we do doing from now on for our patient?
So again, same response as I gave to Zaid, which is that, you know, you need to start asking a simple question about painful diabetic neuropathy. And, you know, you don't need a long questionnaire. You just need to ask, do you have pain, pins and needles in your feet, both feet, worse at night, right? That's enough. So that gives you, that at least gets you at least 20% or maybe 30% of people with small fiber damage. Then, you know, we have got clinical tools, for example, you know, pain perception, pinprick, thermal perception, you know, just hot and cold rods. Those things do give you, they're not exact, but they do give you some indication of small fiber involvement. And then you have to watch this space because, you know, CCM, I think that needs another reboot. I think we need to think about a new instrument, which is maybe a handheld CCM almost, you know.
Thank you, Rayaz. There's another one, could be the similar question. Hanan from Egypt, Professor Hanan. Do you think CCM could be correlated to any simple test available for whole world one day and not to be restricted to only affordable centers because of cost?
Yeah, the thing is, we've tried to correlations and we get moderate correlation, but the problem there is that you've got a very good gold standard test, which is picking up very early disease. And then you've got these other, you know, like say monofilament or not monofilament, you know, even quantitative sensory testing, which is not as exact. So you never get a full correlation, right? But in the future, honestly, what I would like to see is, I think there's technology has moved on. Honestly, if you really think forward, it's going to be an iPhone, right? A CCM on an iPhone, right? To be able to send it, you know, for you guys in outer whatever, right? Be able to use it to pick up corneal nerve damage, you know? That would be my ideal. I don't know, inshallah, that will happen.
Thank you, Rayaz. Anybody from panelists wants to ask? Harry?
Hi, Rayaz. I think what you call is you gave a very good rendition, and I especially like basically when you had the Avengers inside, because I mean, in most lower income countries and middle income countries, that's what we feel like, you know, fighting against odds and all that. Now, for diabetic peripheral neuropathy, I think is a big thing, and you see most of our GPs and also in the peripheries also have a problem of actually assessing and referring fast. Have you seen like basically like India, China, a lot of traditional treatments, a lot of affiliated treatments and all that. Have you seen in your practice or anything along the many years, anything of these things might be able to use? Because one of the things that we looked at is basically looking at resources that are actually used or readily available in low income countries and all that, which might have some significance. I mean, some evidence-based medicine to help. Is there anything that you can see along the whole year that can still be used without what you call this the most advanced methods and stuff.
Yeah, I mean, again, honestly, it comes back to the simple thing that we are not doing, which is even asking taking the patient's shoes and socks off, right? Or just asking them about painful diabetic neuropathy. And I can understand. I'm honestly, when I have my clinic, I have an interest in diabetic neuropathy, and yet I even, by the time you get through the HbA1c, lipids, blood pressure, you've got very little time left. So I think we need to change our systems where actually, and the example I give is diabetic retinopathy, right? And diabetic retinopathy screening. Somebody else does the hard work. As soon as the patient comes through the clinic, you already have, what they have in terms of their retinopathy. You deal with it, right? So again, for neuropathy, I don't see why they can't, the questionnaire can't be maybe done by the patient on a phone before they come to the clinic, for painful diabetes, or somebody else examines them. And when they come into your clinic, you already know whether they do or don't have neuropathy. So, and of course, again, forward thinking, I would love to have, have the iPhone based, scan that's going to be available for everybody just to have, and then we can just deal with it.
Yeah,
but
I think we'll do AI easier. Yes.
Honestly, I don't know. Yeah, but I think we need to, as doctors, we need to think about utilizing other healthcare professionals to do that bit of the work if we haven't got the time to deal with it.
Yeah, we're actually using our diabetic nurse educators and our wound care nurses and assistant medical officers to actually help out. But there are also scars everywhere. That's the thing. Underworked. They're overworked.
Yeah.
Thanks.
Yeah.
Thank you, Rayaz. The next one is from Simone Barbados. She's a regional chair of North American and Caribbean. So she was supposed to be a panelist, but I see her question here. What about the effect of proprioception and also processing of information of diabetes? Has there been any study looking at the small fiber affecting on the brains and education of the diabetes? Any suggestion on a basic assessment for low and middle income countries, how to assess, if there are any studies done on that? So
we have done studies in the past on proprioception and actually balance in terms of in relation to small fiber and corneal confocal microscopy. We do find that there is a very good association. So you have less small nerve fibers, you have worse proprioception, you have worse gait, balance, more falls. So we've shown that previously. Again, coming back to low and middle income, honestly, until or unless the technology that I'm talking about becomes more readily available, easily available, we have to rely on those simple clinical tools, which is asking the patient about symptoms, about identifying painful diabetic neuropathy, and I don't know. Yeah.
Okay. Yes. From the box, another one.
Right.
Which drug would you start in? This is Dr. Sangeeta from India. Which drug would you start in initial stage of peripheral neuropathy and in later in advanced stage, and how would you manage that? So it's important. I'm not talking about painful diabetic neuropathy. I'm talking about peripheral neuropathy. So for peripheral neuropathy, honestly, from the evidence that we have, we don't have a FDA approved drug, right? We don't have one, but there is data there that shows that ACE inhibitors and fenofibrate, at the very least, should be, something that is repairing nerves. And then, the data I've shown you in terms of GLP-1 therapies, maybe SGLT2 inhibitors. So these are, again, the medications that potentially can help repair the nerves. And in fact, we did a study in Qatar where we showed that drugs that cause weight gain, like sulfonylureas, are not good for nerves. They actually make the nerves worse, even though you're lowering the HbA1c. So again, in the clinic, I would want to be my patient to be on the drugs that are making them lose weight. Okay, almost finishing. There's another patient, another from the Western Pacific. I guess in patient with ulceration and amputation, they mostly have abnormal monofilament. Do you have any thought about this?
Yeah, that's what it is. You know, people who've got foot ulcers and amputations have got severe neuropathy. They will have an abnormal monofilament, and if they don't, you've got to ask whether the monofilament that you're using actually works, right? Because you know, there's no doubt those people have got advanced severe neuropathy.
Okay. Is there any role of chemotherapy to CCM? Explain it. That's from Pakistan.
Actually, chemotherapy induced peripheral neuropathy. We know it's a major side effect, and we've done studies 6, 7, 8 years ago where we looked at people with esophagogastric cancer before and after platinum-based chemotherapy, and we showed that there was a damage to the corneal nerves. And there have been other studies from Scandinavia that have shown the same. So yeah, chemotherapy can cause peripheral neuropathy, and CCM can pick it up.
Perfect. Thank you. The last from the boss. What is the role of spinal cord stimulation in diabetic peripheral neuropathy?
If you'd have asked me this 3 years ago, I would have said limited. But there is now data which I think is reasonably robust in people who have failed all other therapies, who will really have quite difficult, painful diabetic neuropathy. And this is the data that's been published in, I think it was JAMA Neurology about 2 years ago, that does show a very good effect of spinal cord stimulation on painful diabetic neuropathy. It needs another study, I think, and a proper study where you've got sham control. That didn't have sham control. It had what's called standard of care. And there is data, but it seems to be good data.
Okay, the last one. Would artificial intelligence be a solution for low and middle income countries where CCM is not accessible?
Depends on how you use artificial intelligence. I believe in the future where I've invented this machine that is really easy, really cheap on an iPhone that scans your nerves. Artificial intelligence will help for sure. There is some data now. I've with some collaborators in QU. They've looked at thermal images on the bottom of the foot, okay, and they show that AI, when you apply to thermal images, can pick up people with early neuropathy, and that isn't very expensive. That's just like a camera, thermal camera that you could literally have the patient come into the clinic, they put their feet up, bang, and you get an answer. So maybe the AI will help there.
Lastly, it's from Professor from Russia, Irina. Professor Irina, she says that what is your point on the small fiber damage in acute painful neuropathy? Is there any peculiarities in damage in comparison with tropical diabetic peripheral neuropathy?
Acute painful neuropathy is a subset of painful diabetic neuropathy, and it's actually, there's the insulin neuritis, which is acute painful neuropathy, which is very different, I think, in terms of underlying mechanism. There, I think acute painful neuropathy is more a vascular-based cause for it. I'm not aware of any studies that have looked to differentiate how much nerve fiber damage there is difference between acute and chronic. Yeah.
Okay, thank you very much. I'll give to my president-elect who's going to give a vote of thanks. Harry.
Thank you very much, to Abbas. I think firstly, I would like to take this opportunity to thank Professor Rayaz Malik for coming in the session and supporting DFO International. It's actually a real pleasure to have you here. And even though post-COVID and all that, we find that the hybrid system or even the online systems are still very effective, especially for most of our regions, because we got 7 regions under DFO International itself. At the same time, let me thank Dr. Abbas for his leadership, Dr. Vijay, and the whole board for actually supporting this particular education sessions, and more so also to all the regional chairs, the regional committees, and the delegates who have actually come in, and not to mention and not to forget, basically, Ali, our secretariat also, who has been very supportive with our sponsors and all that. I would like to take this opportunity to thank you all for attending this session, even though in some places it's early in the morning, some places late at night. But one thing is, at least it actually is something that we are doing along the way. And like what you have mentioned and what you have showed, basically, as I mentioned earlier about the Avengers, all of us are coming from everywhere else. And our only aim in life, I mean, at the moment now, is to prevent avoidable amputations. And these kinds of education series will be very helpful. So with that, thank you very much and have a good weekend.
Thank you, Harry. I would just say again, thank you very much, Professor Rayaz Malik, to open this and to accept my invitation. It's really privilege. And we can see up till now, it's about 200 participants are still there listening to you. So how active and how much you have vibrated them and stimulated them. That's really fantastic, I'm telling you. And Harry has already thanked the board members, the regional chairs and advisory and everybody and the IT here locally. I would like to thank the delegates because without them, these webinars are not possible. So a very big thankful from our left ventricular. Thank you very much. Thank you. Thank you again, Professor Rayaz Malik. Thank you.
Thank you.
Yeah,
Goodbye.
thank you.
Thank you. Take care.
Thank
Goodbye.